Thank you very much for the invitation. What I'd like to talk about, again, I was given a title, so I've had to fit my usual spiel around the title, is to take radon as a health threat and I suppose to think a bit about where there are going to be barriers to try to instill the kind of behavior change that we would look for in terms of promoting health. So, if we think about radon, it is the greatest health risk from radiation in Ireland. Yet, when we ask people about radiation threat, it's nuclear power plants that people think of. We know that as a known carcinogen, it's in the same category as tobacco smoke and asbestos. It is the second leading cause of lung cancer following tobacco smoke. Estimates in Ireland would indicate that about 250 people every year have a diagnosis of lung cancer linked to radon. So that's about 2 people every 3 days. Within 12 months with lung cancer, about 2 out of 3 people are dead. It has a very low survival rate. So radon is a threat to health, but it can be managed. And so as part of what I was interested in and the work I was commissioned to do by the EPA was to look at, well, what is the effectiveness of the kind of public health campaigns in terms of being able to produce behavior change. But what I want to spend most of the day talking about is really around, well, what are the kinds of psychological barriers that basically act against the effectiveness of these messages. So radon can be managed. We can test for it, which is akin to screening. And if we find that there is a threat, we can take preventative action to minimize the threat. So this is a threat that can be managed. It's not a threat that's problematic because of a lack of education. So there's quite often a starting point, which is if we just give people information about health threats, well, then that should produce behavior change. But we know from numerous surveys here and in numerous countries, there are generally quite high levels of awareness of radon. But when you ask people more about it, they're not really that sure about or that bothered or that concerned about long-term health consequences. And we'll come back to some of the psychological factors that can act to kind of stop us thinking about long-term consequences. We know that in general, levels of testing for radon are quite low. Even when you tell people that they have high radon levels in their homes, remediation rates are particularly low. So you've been told now there is a threat in your house of lung cancer coming from radon, and maybe about 1 in 4 will actually go on to do something to remediate against that threat. So I said a lot of the work that's been done in this area, nationally and internationally, has been based around identifying regions that have high levels of radon and then coming in with quite elaborate and complex community-based programs with various educational strands in them. And the idea is that if you tell people there's a threat, that they're going to respond in a rational way. And what that would look like is you're told that there's a threat there, and therefore you should be motivated to do something to see, well, does it personally affect me? So I should do something, i.e. test. And then what I should do is, if the test indicates that there's a threat to me, well, I should do something to remediate that. I should try to reduce that threat. I should then probably also check to make sure whatever it is I've done has actually been effective. So that's the kind of simple version of what should be happening. But if you break it down into all of the various steps that need to happen to get from an information delivery to actual behavior change that is going to be of a health benefit, people have to be exposed to the information. They have to attend to it. So putting information up does not necessarily mean anyone will attend to it. They have to be interested in it. They have to understand it. They have to see the information as being credible. It has to be comprehensible. They then have to have some sense that maybe there is a threat here. And a threat requires us to think of two things. The first is that it could affect me so that I am susceptible. And the second thing is that whatever it is that's there could be negative. So it has to be both susceptible and severe. I then have to think and believe that that can be assessed. I have to know how to get the threat assessed. I have to want to do it. And then finally, I get to doing it. Now I have to get the results, which I have to understand. I have to then interpret them as suggesting that, yes, I am at risk. I then have to want to reduce that risk. I have to know how to reduce it. I then have to act and do something. And then I have to confirm. That's a lot of steps. And at each of those steps, we have a get-out-of-jail card, where we basically just lose interest and don't follow through and proceed to the next step. But really what this is trying to highlight is this is quite a complex process. It's a mixture of knowledge, beliefs, feelings, motivations, and behavior. So said one of the defining characteristics that comes through from the literature is, despite high levels of awareness, by and large, people's response to this threat is apathy. If you offer people radon tests for free, just above 1 in 3 will actually avail of it. If you give people the free test and tell them you have a high level, therefore you and the people living in your home are at increased risk of developing lung cancer, maybe 1 in 3 will plan some action. That's not do anything, that's plan to do something at some point. So what it is about radon that means we can hear about a threat, but basically not really respond in an immediate way. Okay, well, it fits a number of features of threats that we know from the psychological literature are just really hard to get people motivated to do something about. It's quite a low objective level of risk. So when you tell people about levels of risk, if that's such a lowish level that we know people struggle with understanding probabilities, particularly probabilities in relation to things that are very low, so it's easy to dismiss. There's no sensory cues. So again, we know that where people have clear immediate sensory cues to action, like smells, like tastes, like things that are visible, then they can act in response to it. But in essence, radon is silent, tasteless, odorless. Therefore, we've no cue to tell us there is a threat here. It's a natural risk. And we know from decades of research, people get far more upset about man-made threats than natural threats, because things that are natural, we somehow seem to automatically associate with being good for us. So there will be more outrage over a radiation threat associated with a power plant because that's man-made, or with power pylons because that's man-made, than something that's naturally occurring. It's a relatively benign risk, and what I mean by that is that basically people can live with this risk for decades. There's no side effects while you're living in the house, there's no real symptoms on a day-to-day level, so you can live with it, you can tolerate the risk. The effect is far removed from initial exposure. So again, lung cancer developed decades later. There's no early symptoms, which means you can keep on delaying action. And again, people have quite interesting perceptions of control, insofar as people fully believe that they can undo damage in the future that they're doing today. So I can do something in the future that reduces my risk, but I don't have to do anything now. The deaths are relatively undramatic. So we don't get 6-1 News saying that somebody died from radon today. And again, we won't get a level of threat perception about that because it's not part of discourse and it's not dramatic. It's inequitable, and we really don't like this. We don't like the idea that due to chances to where I'm living, I'm at threat of something bad happening, radon, and you're not, even though you live across the road. We struggle with those types of risks and therefore don't act. There is an emotional identification with our homes. So again, we think about our home, which is our place of physical and psychological safety. The idea that this is a threat to our health and is causing lung cancer does not fit with our perceptions about what our home should be. And rather than act to basically make our home safer, we basically just do nothing. So radon, as I said, really ties into a lot of the core issues that have been present in the psychological literature on risk perception since the 70s. Risk perception is not just a simple actuarial model. It's a complex psychological process of meaning making. we have to perceive the threat as being credible. And again, I like the idea that if radon is being described as a health threat, it should always be described in the health area. Because once people put it in the environmental space, it's no longer a health threat. It's something else, and therefore can be discounted. We know that there are numerous biases that we have in how we process information that will basically impact on how we come to act from it. So we can't really recall people dying from radon, so it can't be that much of a thing for us to worry about. Radiation comes from nuclear power plants, not from our home. People generally are unrealistically optimistic. What that means is that, by and large, we think bad things are more likely to happen to other people, because that's kind of worrying if they're likely to happen to us. So other people will experience bad things in life, not us. So all of these biases will exist to minimize our sense of risk. But the other thing that's important about risk perception is that too often we leave it in the head of the individual. Risk perception and threat perception happens in a social context. So a simple example is, if the fire alarm goes off here, what are people likely to do? Well, if you're like most people, what you'll tend to do is stay still and look to your left and look to your right. Now, if you were doing that out of a concern for other people's well-being, that would be great. But you're probably not. You're probably looking around to see, well, what are they doing? And it's the same with other health threats, and particular radon. So what are my neighbors doing? What are other people in the community doing? Because if they're doing nothing, well, then I'm not going to do anything. So health threats are presented to us routinely on a daily basis, on a weekly basis. We get exposed to more and more things that are bad for us, that are threats to our health, and we end up just discounting them because there's just too many of them. But we respond to them in two ways. We think about the information, but we also have an emotional response. And what people tend to do when presented with information that is upsetting is to respond defensively to it. And what that means is we can suddenly start doing things like questioning the accuracy of the information. So if you tell people radon is this colorless, odorless gas that can cause lung cancer, the first half of that sentence they won't question. The second half they'll start questioning. Suddenly they'll become epidemiologists. What do you mean by evidence that this is going to cause lung cancer? What was that study based on? What were the data like? People will start questioning bits of the message that they don't like, and they'll bring a very skeptical view to it. By and large, we're characterized by a way of looking at information and being exposed to health threats that has a bias in it. And the bias in it is, allow us carry on doing what we've always done. We are creatures of habit. So things that we have been doing that give value in our life, that give meaning in our life, that give pleasure in our life, we won't give up in the face of evidence or in the face of information that may force us to change. What we'll do is we'll start processing that information in a way that basically protects ourselves and our sense of self. And our sense of self is far more valuable to us than any abstracted notion that we might develop something decades down the line. So when we think about informing people about threats, we need to be aware that there are these biases in how people process health information. So when we look at programs that have been set up to try to enhance screening and remediation, again, they're quite good at helping improve people's levels of knowledge and getting people to say that they intend to change behavior. But we know that intentions aren't that good. Every new year, people make lots of intentions. How many people actually go to the gym as often as they said they will? How many people a few weeks later are following that new diet that they swore they're going to do? So getting as far as intentions is good, but when you look at actual behavior change, there's quite a big gap. So very little evidence of these programs having an effect on actual testing rates or remediation rates. Even those who actually get a kit to screen very rarely actually go on and do anything about remediating their house. Now, within the literature, there are problems. So a lot of the studies aren't very well designed. We don't really have routine objective assessment of actual remediation rates. So that is problematic. But the general trend is pretty consistent across the literature. Programs work to help people feel they know more about radon, but they generally still don't do anything. If we look at the Irish context that have been delivered by the EPA over the decades, broadly we're finding that how they're delivered, what happens in them, the process of delivery is comparable to what goes on in the international literature. It's in line with what the WHO recommends for risk communication. But by and large, the level of impact is pretty similar, i.e. minimal. So in thinking about radon, as I said, we need to look at, well, what should we expect from health intervention programs? Because I think sometimes we can get caught up in damning ourselves with the ineffectiveness of interventions, but sometimes it's useful to benchmark, well, how effective are other things? So if we think about what radon awareness programs have tried to do, they've tried to get people to test, and they've tried to get people to remediate. Okay, so that's akin to screening and prevention. Okay, so do people always go for screening for health threats? Quite often they don't, because people don't want to hear the bad news, because that might have an impact for a negative sense of self. When we look at health threats that are more familiar to us, for example, cervical cancer or breast cancer screening, when you go into large-scale communities and you present these types of broad-based education programs, you might get behavior change in about 4% of the population. That's what a known risk, cervical cancer. Then radon risk, people aren't too sure what it is. If we think about promotion campaigns to try to encourage preventative behaviors, again, using similar multimedia, well-funded, well-resourced, well-developed, well-delivered programs, you probably get behavior change of about 5 to 15%. So I think we need to be very clear, bottom line on this is, behavior change is hard. Education campaigns in and of themselves will have some effect, but they're not going to have massive effects. So we need to think about how we deliver these programs to try to overcome the biases that people have in perceiving risk. So when risks threaten, there are emotional and cognitive mechanisms that will push people towards action, but there will be more that will pull them towards inaction. And that's that relative balance that we have to strike. The threat from radon is too easily downplayed. Again, we can keep on justifying inaction. It's distal, it happens sometime in the future, it's only every now and then in the public discourse, and we can always think that we can act in the future to undo damage. Indeed, we know from studies in the US, this is what people will actually say to you. They will say, I know I've got a high level now, but sure, I can do something in a few years' time. Every day they're in that house exposing themselves to a carcinogen. So what we know from decades of health psychology research is that even well-designed, well-delivered information programs are seldom adequate to bring about appropriate protective behaviors. So it's not that we're doing something wrong in our education campaigns. We're doing them about as well as we can do. We may just need to be more realistic about what level of behavior change is actually achievable in terms of population or community health interventions. Doyle and colleagues back in the early 90s talked about any radon program that relies only on information, awareness, and voluntary testing is likely to fail. At the very least, any credible mitigation resulting from the program has been so small as to suggest that some programs may be very expensive ways for society to achieve mitigation. So what this suggests is that we may need to think about the balance of where we're putting on the individual versus the state. That governmental regulation may actually be preferable. And again, the WHO acknowledges this, that says convincing policymakers to take action to regulatory means may be more effective than risk communication messages targeted at general public. So this does raise, I suppose, issues about where the state's role is and where the individual's responsibility lies. And again, there are a number of options that could be taken from a state legislation perspective. For example, we could look at testing as being part of the house selling process, and it may well be that you have to have a test prior to sale, or you have to test a remediation prior to sale. So there's a number of options here. But really what all of these are trying to do is to try to shift the onus of behavior out of the individual from a voluntary perspective and putting it more under a regulatory focus. Okay, so one other possibility we might want to think about for radon is to think about the visibility of the threat and the visibility of the remediation. So it's an invisible threat and therefore, like kind of air pollution, can just be negated. How do we make the threat more salient? Well, monitors in houses that can give readings and can have flashing red lights, possibly combined with beeping red noises, might tell people that there's a threat here now. And we know from some of the literature that when people have visual or auditory aids, that can change behavior that might otherwise be forgotten. So again, it's about trying to do something that gets us out of our routine habit. We can also put visible markers on houses that will indicate that when houses have been tested, for example, to basically send a signal to the community that actually we have tested, and therefore we've done the right thing. And what we can sometimes hope for is that maybe over time, the more and more people that are testing, the more deviant it is now to not test. So the more that testing is the norm, then non-testing becomes the deviant thing to do. So you're the one who's the bad person because you're putting yourself and your family at risk because you're not testing. So this idea draws upon a lot of work that happens in behavioural economics, talking about social herding, about social competition and social herding to change behaviour, and not just it being about at an individual level. The final issue that can sometimes work is to think about, rather than looking at people all at the same stage around the threat, is to think about people being at different points in the decision to change. So thinking about message segmentation. So again, there may be some people who've never thought about testing, and how do you facilitate getting them to a point of testing, where there may be others who have thought about testing, but aren't quite sure what to do next. And we know from some of Weinstein's work, particularly in the 80s in the US, that you can develop interventions that meet people at their point. So you can get interventions that match where the person is in relation to thinking about the threat and threat management. Okay, so I'm going to just do this. So what I've hopefully given you a sense of in the context of Radon is that when we look at health information campaigns, I said it's not just about providing information. We need to think about, in essence, the message recipient and the kinds of ways in which they're going to process the messages we give out. Because without trying to understand the message recipient, and that may be at an anthropology level, I would probably argue at a psychological level as well, we are going to get stuck in terms of how effective our interventions can be. So what this, I think, suggests is that for some health threats, it may well be that we're putting too much responsibility on the individual, and it may well be that the state may need to get more involved in this process. So there may well be a requirement to think about increased governmental regulation, whilst at the same time providing some information campaigns that are there to help inform people. But if we want to change behaviour, said relying purely on individuals to do this is a tough ask in light of a threat like radon that can be easily discounted, and which I think is like many of the threats that have been mentioned so far from environmental health threats. Thank you.